I will talk to him more, some personal conversation with him towards the end of this hour. But bottom line, he has been the guiding light for bladder cancer for the longest time. He was asked to chair the Society for Urologic Oncology panels, as also the SIU, International Panel of Bladder Cancer, twice in a row. His interest is in bladder cancer primarily, but also in prostate and kidney cancer. Numerous honors and awards, the Gold Cystoscope, the Presidential Citation in 2009 from the AUA, and multiple international associations, over 500 peer-reviewed publications, over 500 visiting professorships. You can go on, and we'll talk a little bit more about this later towards the end of the session. But when I called and requested Mark to do this with our team, he jumped at it and was just most gracious. He has been, as you might recall, our visiting professor at some of our annual urology conferences and at Practical Urology Conference at USC. So it is with great pleasure and a lot of warm feelings that we invite you back, Dr. Soloway. I'm going to turn the podium over to Dr. Ann Schuckman. She's going to be the host for this morning's event. Ann is our urologic oncologic surgeon and has been at USC for over 10 years now, does a phenomenal surgeon and one of our leaders in urologic oncology at USC. So good morning, Ann. You're muted.
Yep.
Yeah.
Good morning. So welcome to our conference this morning. And Dr. Soloway, thank you so much for coming as a speaker for us. The way we'll run things this morning is first we'll have you give about a half-hour talk on If I Knew Then What I Know Now, 5 things about bladder cancer. And then once we're done with the formal presentation, we'll have a panel of our chief residents to do some case presentations. So without further ado, Dr. Soloway, the floor is yours.
Well, it's certainly an amazing opportunity to do this. This is my first Zoom conference ever, and usually I'm not horribly nervous getting up and giving a talk, but thanks to Gio, I'm not the most computer literate person, and we've got this going so far. That was my main thing, is this really gonna work? Even though I watch the news all the time and they do this, they're professionals. So I'm really looking forward to giving this talk. As Dr. Gill knows, we were supposed to be in Amsterdam, and this all originated from a letter from Dr. Montorsi a little bit ago. Before I start there, I just want to tell you I'm very familiar with the USC program. Dr. Gill and I shared Cleveland, Ohio. That opportunity, I grew up there, and of course, I was very familiar with his fantastic career there, and then having the opportunity to relaunch, if you will, the great program at USC in Palo Alto. In Pasadena, sorry. At any rate, so this is going to be, I hope, fun. Originally, the talk was going to be absolutely 20 minutes, and this now gives me the opportunity not to go real rapid like I would sometimes have to do. So I put in my email here because I hope, particularly with this opportunity where everybody isn't going crazy with patient care, quite the opposite, that some people listening to this may be reluctant to voice questions with everyone in the room, if you will. So there's my email. I absolutely enjoy interaction, particularly with residents, fellows, faculty, about a variety of different things. It's kind of, will be our personal Facebook. So anybody in the room who wants to email me with questions, comments, critique, be my guest. So let's see, why is the next slide? Here we go, let's do it this way. So here's Dr. Gill, and one of the very few times that I've actually seen him lying down. That's very rare, as you know. And this was a few years ago in Cartagena. Here he is. Can you believe this guy actually is lying down? This guy must have more caffeine in his body than any 12 human beings. And here we are, thanks to him. I couldn't believe I would actually one day be in Saudi Arabia. And this was an amazing opportunity for me. You can see us with at the bottom after the party, joining these established and well-known people in that country. And what a great opportunity. And thank you, Indy, for that amazing opportunity. So Dr. Montorsi asked Dr. Gill for kidney cancer, Peter Carroll for prostate cancer, and myself to take 5 areas. He called it mistakes, but really 5 areas where we saw a problem and we said, what can we do about it? Or it could be a mistake, but I took it as more as an opportunity. Now, this is a long period of time, which I'm going to cover. So I probably, virtually everyone in this room, probably everybody but me, wasn't even born in the 70s. So I thought a trajectory would be really important. So for myself, I started my general surgery residency in Cleveland, Ohio, in the University Hospitals in Cleveland in 1968. I spent 2 years there. And then instead of, fortunately, if you will, I would have had to go to Vietnam, let's put it that way. But I applied to the National Cancer Institute, and I was one of 5 people to get into the surgery branch, and I was there for 2 years. That's before my urology residency. When I left the NCI, I then went to University Hospitals in Cleveland under the chairmanship of Lester Persky, and that was my residency. Then after that, I went to my first faculty position at the University of Tennessee in Memphis. I went there for several reasons, but one, it was the biggest private hospital in the country at the time. And in 1991, I had the opportunity to chair the department at the University of Miami. And then I was, when I stepped down, they offered me the current opportunity to be chief of urologic oncology in a very large hospital group in Broward County in the Miami area. So I have to take you back so you understand what things were like in the 70s. And again, I fully realize that some of you are saying, who was Richard Nixon? What's this about the Vietnam War? And you see one of the leading pictures at the time, motion picture, and here's a Volkswagen. And again, just things, Elvis Presley, that's another different story. And since I was in Memphis, I was obviously well aware of him. Being Miami, of course, the Bee Gees are part of history here. So you can look and see what the computer was like. The thing on the bottom left, many of you don't even know that's called a typewriter. And one of the things I was going to be giving this talk in Europe, and I look, what's topical in 1970s? And here you see Time magazine, the man who will be king. Prince Charles was about to be the king of England. And here we are in 2020, and he's still not the king of England. So it just shows you some things you just can't figure out what will happen. So we're going to just limit this to bladder cancer, 5 areas for improvement, if you will, mistakes. So the first thing I thought I would do, and if some of you remember, we used to get the Journal of Urology, and we were stupid enough to bind them. And actually I have some of those. And so I said, well, to give this talk, I'm going to actually open up the 1972, 73, up to 75 Journal of Urology, and let's see what the state of bladder cancer was. And so here we see an article from Roswell Park, big cancer center in Buffalo, current results from stage C and D bladder cancer. And this is amazing. Look here, this is cases they put together from 1960 to 1969. No CT scan. So you made your diagnosis by a TUR BT, an IVP, and a bimanual exam. And that was your staging, if you will, and diagnosis. And only 20% of the patients even had a cystectomy. 90%, their primary treatment would be radiation therapy, sometimes with or without surgery. And the only chemotherapy in those days was 5-FU, and 80% died of bladder cancer. I mean, amazing, isn't that? So at the end of that article, they said it is unwise to suggest a routine form of clinical management for these patients, and we're doing terribly. So let's look at another center. Here's Cornell, article in 1973. 94 patients, both quote stage C and D1, D1 of course being a lymph node metastasis. Overall survival 13%. Dismal prognosis. Hope that new modalities such as chemotherapy or pre-op radiation will provide some improvement. Okay, so the group in Baylor published in 1973. Let's see what radiation does in combination with surgery. So if you look here, 3-year overall survival, again, the numbers are very small. For surgery alone, 8%, 1 of 13 patients survived. If you add radiation, 27%. Say, well, we're making some improvement here. However, their bottom line, treatment of invasive bladder cancer remains unsatisfactory. So here is this guy, looks kind of interesting to me, mustache, etc., off to the NCI. So the number one of the 5 topics, how can I improve the dismal cure rate for locally advanced bladder cancer? So part of the 2-year fellowship there was to do research. And this is in 1970, 72 when I was there, and I'm thinking, what am I gonna do? So I happened, totally by chance, to come up with an article that one can give mice, rodents, a compound called FAMP, somewhat related to the macrodantin area, if you will, biochemically, and they will get tumors histologically very similar to the human. I was at the NCI, there was no budget. I said, this is what I want to do. So loads of syngeneic C3H mice came in. I started giving them this compound. Sure enough, they developed tumors, just like that article said they would. And then since they're syngeneic, I was able to take the primary tumor and transplant it to the hind limb of a syngeneic mouse, and I would have a more rapidly and measurable tumor. And actually, one of the first articles, I was asking Gio last night, and he got 100%. I said, if you have these mice running around in these cages, how are you going to know when they have a bladder tumor? And he correctly said, number 1, blood in the urine. So I would pick them up. They have blood in the urine, then I'm going to sacrifice, see if they have a tumor. And I actually used urinary cytology, which he said also would be another modality. And a first article I published in Urology was the use of urinary cytology in mice to see if they have a bladder tumor. Now this gentleman, in my view, should have won the Nobel Prize. Barnett Rosenberg of Michigan State University, who nobody in the urologic community knows, because I've asked people at panels and audiences, et cetera, and it's very unfortunate. But in 1965, he discovered this compound, cysteamine dichloroplatinum. Well, obviously, the reason I bring it up is I intertwined with that discovery in this fashion. So I had this animal model. I realized we need systemic therapy for the treatment of this bladder cancer at this stage. And I went over to the pharmacology division at the NCI and I said, do you have any new drugs that I can test? We only have 5-FU so far in the clinic. It doesn't work very well. We have this new compound, they said, cysteamine dichloroplatinum. We don't think it's ever going to make it to the clinical use because of the nephrotoxicity and other toxicities, but here's a few vials. Go test it. So I did, and I figured out a dose that they would survive. And it worked. Comparing animals who did or did not get platinum, there was a very dramatic difference. And so I went to the surgical forum at the American College of Surgeons, and I presented my data that it seemed to be quite helpful. Someone in that audience, well, and then I should mention that I began to publish the articles towards the end of my time there and during my residency, chemotherapy, experimental, transitional cell carcinoma. And I should mention one of my chief residents was helpful for me in transitioning from the NCI, and that's someone who well known to some of you in the LA area, Jean de Kernian, who was really a wonderful mentor during that time as I began my urology residency and I want to continue my laboratory work. So that's exactly what I did. I took my mice in the back of the car with me to Cleveland, Ohio, and during my residency, while I was learning how to do cystoscopy and TURs and et cetera, I was running a laboratory continuing this work with bladder cancer. And then I went to the University of Tennessee, my first faculty position, with this understanding about this drug cisplatin. None of the medical oncologists there knew anything about cisplatin. So I knew as a beginning faculty member much more about this particular drug and bladder cancer than most of the medical oncologists, if not all there. So this gentleman was a very important mentor. Alan Yagoda, who unfortunately passed away a number of years ago, was at that time at Memorial Sloan Kettering. He was there when I gave my talk at the Surgical Forum, and he came up to me, he says, "Look, Mark, this really works." I said, "Well, at least in the animal model, and I think it's a good model." He said, "Well, we think we now have a way where this can be given to patients." So for the next several years, I interacted with Dr. Yagoda because here I was going to give the drug myself because there was no medical oncologist. And I also interacted with these people: Chris Logothetis, who currently still is at MD Anderson; Derek Ragavan, at the time was in Australia. He subsequently, as Indy knows, went to the Cleveland Clinic. Howard Scher and Cora Sternberg were both at Memorial Sloan Kettering. And they were also, Howard and Cora were fellows and then faculty, along with Alan Yagoda, in setting up, establishing not only cisplatin alone, but systemic MVAC. So here am I, out of the archives, if you will, giving cisplatin, this is obviously a model here, to my patients. And I actually wrote an article in the, I think in the Journal of Urology, the use of a nurse practitioner, because I was a busy surgeon like all of you, or most of you in the audience, and I couldn't have time to take care of the patients, but there was no one else to give it. So I understood from my contacts with the medical oncologist how to give it. And within a short time, here's Alan Yagoda's, one of his first publication, 24 patients, 35% partial response rate, far better than what we had prior. So looks like this drug was going to be quite useful. And then I published my own data in 1981, first in 78 and then in 81 in these various journals. And I said my response rate is quite similar to what they have at Memorial Sloan Kettering for locally advanced and metastatic urothelial cancer. And as you well know, that for 45 years, this remains the most effective systemic therapy for advanced urothelial carcinoma. I think we should put parentheses right now. We may be finally getting a new era where with the immunotherapy, the Pembros, et cetera, that we may have an agent that'll work with cisplatin or instead of it. But until now, this has been the primary therapy for metastatic and locally advanced bladder cancer. So number 2 topic is, can we improve the results of bladder preservation? Because even today, and certainly was in the 70s, as I already noted, external beam radiation therapy was the primary treatment for a very high percentage of patients for a whole variety of reasons. So here's my animal model. At this time, I was in already Memphis, Tennessee, and I said, look, if our patients are getting radiation, why not see, at least start in our animal model, whether radiation can be benefited by the concomitant giving the patient, in this case the mice initially, cisplatin. And we wrote this article based on our animal studies, the primary murine bladder cancer, both in the metastatic model and primary, showing the additive effect of cisplatin and external beam radiation therapy. Then I went to patients and I published that in 1982, that it seemed to be beneficial for these patients. And then at the time was the National Bladder Cancer Project funded by the NCI. And in the leadership was George Prout, who is currently chief at the MGH, and Bill Shipley, chief of radiation oncology at the MGH. And they did a preliminary study, cisplatin and full dose radiation based on the animal model and my initial clinical small scale study. And then there was a much larger multi-institutional study, which again confirmed that cisplatin added to the benefit of radiation for patients unsuited for surgery, published in JAMA in 1987. And then I realized, look, if the chemotherapy works, and this was 1987, that why do we use this before surgery? as a benefit to quote unquote downstage patients. And that I indicated at that time, and as you know, finally in 2003, it takes a long time for these things to be really proven in randomized trials, that neoadjuvant chemotherapy is currently a guideline, although certainly not used in a high percentage of patients, but that's a different story. So that was number 2. Now we're going to switch to other stages of bladder cancer. And as you may or may not know, I don't really like the term superficial, which finally I got rid of with several editorials. But even non-muscle invasive bladder cancer is the same misgiving in that it doesn't provide an accurate determination and separation among the grade and stage within non-muscle invasive bladder cancer. So that's why I titled this part TA, T1, and CIS. As you know, there are 3 totally different malignancies depending on grade. So what's the problem here? What can we address? Well, why do we get subsequent tumors? The so-called recurrences usually are new tumors. And again, let's open our 1972 textbook. And here we see the state of the art at that time. And here's someone actually talking about mucosal stripping to decrease recurrent superficial cancer of the bladder. So that's where we are. We're just learning in the 70s, how do we deal with these recurrences? The only, here is a comment, one of the most challenging features of superficial carcinoma of the bladder is its tendency to recur, often in an unpredictable pattern, which we're well aware of. And why does this happen? Well, of course, carcinogens, cigarette smoking is probably the leading reason. Incomplete resection is also a significant aspect, but maybe implantation occurs. And there were, prior to the 1970s, even the 60s, people suggested, because often at that time, you might know that they were doing open removals of bladder tumors, opening the bladder, removing them, and then closing the bladder, and say, well, maybe implantation is occurring and can tumor cells get outside when you open the bladder, etc. So I said, well, geez, I have a way I can determine, at least in the animal model, maybe if I can establish the model, whether implantation really is a factor. Let's prove it. So I said, how can I simulate a TUR? Because maybe it has to do with the TUR. As you know, primary tumors in the bladder usually begin on the trigone. That's the most common site of first tumors. But later, as people have subsequent tumors, you start seeing them more and more posterior wall of the dome. Maybe we are perturbing the environment in the bladder as a result of the TUR, and these tumor cells are viable. So what I was able to do is to take female mice, cauterize the posterior portion of the bladder, get them to survive, and then did a very simple study. Tom Weldon was a junior resident. I was a mid-level resident or senior at the time. So what we did is we took the MBT tumors. I was telling Gio last night why I called these MBT, mouse bladder tumor 2 and whatever number. And I said, I should have called it the Soloway bladder tumor or MS tumor. I was so stupid, I didn't do that. So no one knows where it arose, but that's okay. So at any rate, I took these 3 groups of mice. So on your left of the screen, you will see when we have a normal bladder, we don't cauterize, put in our large number of tumor cells, no tumors, of course, develop. On the right, I cauterize the bladder. That's not going to cause any tumors. But if I alter the bladder surface by the cautery, then put in the tumor cells, and then sacrifice the mice, 80% developed a tumor. So at least in this model, if it has anything to do with our TUR BT, implantation can occur and does occur. So I said, well, it would make sense to use intravesical chemotherapy afterwards. If we're leaving these tumor cells there, they're causing a subsequent tumor, why not put in chemotherapy? And that's when I started writing articles after publishing about our model, and other people also able to reproduce that, talking about prophylaxis of bladder tumor implantation and the rationale for intensive intravesical chemotherapy for these type of tumors. And then more specifically, wrote a number of articles about the use of mitomycin C and the side effects associated with that agent to allow many people to have that experience and use of this drug. Certainly was safer than thiotepa, which caused myelosuppression. So again, it takes a long time. And finally, randomized trials. This is the most key one from Talley et al. In the UK. Either 1 or 5 installation will decrease the recurrence rate. And as you well know, that is now a guideline for use of intravesical therapy after a TUR BT. And just FYI, the MB2 tumor still this day and age, I just looked at PubMed and say, is this still being used? And if you pull it up, the MBT tumor, I don't have it anymore. I haven't had it for many years, but it still is available for those interested in using it. So the number 4 topic is, let's talk a little bit about low-grade TA bladder tumor. Because here, of all the things I've mentioned, is where we can make a major impact by the average urologic community. And what am I talking about? So this is a tumor we're all well aware of. It is the most common bladder tumor that the average urologist will see. Low-grade TA bladder tumors, you see the gross. All of you recognize it immediately as urologists. This is obviously a low-grade TA tumor. And once the patient returns, having had maybe a large one to begin with, the subsequent tumors often are very small and are obviously low-grade TA tumors. So again, we're talking about grade 1 and 2 in the old grading system. It's the most common bladder tumor. Patients do develop subsequent tumors, but they rarely will later have an invasive tumor, even T1, much less T2. However, the standard practice has always been, until very recently, when you see a bladder tumor, you take the patient to the operating room and you remove the tumor. That's been absolute for urologists for as long as I can remember. So the TUR BT, of course, requires usually general or spinal anesthesia. You're supposed to remove all the evident tumor. And again, this reason for a TUR BT is to determine the accuracy for grade and stage, and that will be your prognostic information and what your plan is. And this, again, we're all familiar with that procedure. So, however, the importance of grade in what you do is not new at all. In fact, in 1972, this magic year I keep coming up with for obvious reasons, there was an article, this is hard to believe for those of you who weren't even around in this period of time, a computer analysis of 500 so patients. And what they were using was IBM punch cards for each patient in St. Louis at the time. And the conclusion of this Journal of Urology article was, if the patient has a grade 1 tumor, they have an excellent prognosis. And here's another article, The Natural History of Papillary Transitional Cell Carcinoma, and 365 cases, 50s and 60s, very long follow-up, treated with TUR only, and only 5% of the patients died of anything in that period of time, much less bladder cancer. So 36 years ago, based upon my understanding of bladder cancer, I wrote this article. Surveillance of stage 0, which is TA, grade 1 bladder cancer. Could we just monitor those patients with cytology? Bill Murphy was an amazing urologic pathologist that I worked closely with in Memphis, so I used to look at histology and cytology with him quite frequently. Cytology is excellent for high grade, so if a patient has low-grade TA bladder tumor, which in our current terminology, why not just periodically do cytology? Kind of, maybe say that's ridiculous. Well, it does make some sense. And if the cytology shows no high-grade cancer, you can make the interval much longer in between endoscopic and invasive management. So I published that in 1984, and we'll go forward now. Here's a much more recent article showing nothing has changed. 23-year mean follow-up. This was published in 2005. And these patients with grade 1 TA, long follow-up, only 12% progressed, only 3% to T1, 12% progression in grade, only 3% to T1, and no deaths of bladder cancer. So the point is, and I think all of you say, oh, I know that, okay. Grade 1 TA tumors don't kill anybody. So therefore, can these patients be safely observed? Why? Well, decreased multiple visits to the operating room, avoid repeated trauma to the bladder, reduce the morbidity from the procedure, and particularly anesthesia in elderly patients, often on anticoagulation. So in 2003, this was the very first article, Expectant Management. So what I said is, okay, if I really believe this, I'm going to do it. So I would see patients, this was when I was at the University of Miami. They had a small little bladder tumor, a subsequent tumor after the initial TUR. I'm just going to follow them. Come back in 3 or 4 months, we look again. And in fact, not surprising to me, no patient progressed to a muscle invasive bladder cancer. So that was the first article on active surveillance for low-grade TA bladder tumors. And then came, thankfully, initially from Israel, and then from Spain, and then from, I believe, in Italy. Subsequent papers, I won't go into the detail, all showing the same thing. When you remove these tumors eventually because they grow or the patient has bleeding, they're virtually all TA, and none of the patients in any of these series died of bladder cancer or even developed a muscle invasive bladder cancer in follow-up. So therefore, low-grade TA patients, I think you have alternatives. You don't have to do a TUR BT every time you see them. You can monitor them if they're very small and lengthen the interval between endoscopic management other than cystoscopy, or do office cautery. This again is to just highlight eliminating the term superficial bladder cancer. Hopefully it's eventually is now gone. And this is one of the articles. So again, the TUR and management of the patients, we've come a long way. I was fortunate to be one of the first in the US in 1985 to have a flexible cystoscope in my hands. And that was a revelation, although it took quite a while for the urologic community to say, I can't see anything through that thing. Remember, we didn't have the video at that time. You had to look through the lens. And yes, going back, I had the opportunity after many years of video to look through, and I said, I can't see anything. But at the time, I thought it was amazing, and it was certainly great for the patients. And so here today, this is a very frequent procedure, and I use office cautery on multiple times per week for these patients. So low-grade TA tumors, recurrences that I can see, and I'm pretty sure these are low-grade TA, I routinely use office cautery. And people also now are publishing using the laser. Office treatment for low-grade TA, this is from Scandinavia, 21 patients with prior low-grade TA, emphasizing the cost benefit and the benefit to the patient. And here again, the example, none of these patients progress, large cost saving, and patient can quickly come and go, and it's time saving for everyone. So why office cautery for low-grade TA? You avoid the operating room, avoid general anesthesia, time saving for the patient, all the money with preoperative workup, EKG, letter from their primary, time saving for the urologist. You go to the operating room, it's going to be at least an hour. I don't care how short the case is. Whereas if you're in the office, you just go to a different room. Within 5 minutes, you've concluded the procedure. And of course, I think eventually it would save a lot of dollars. So I would like a lot of comments on this. And I know it's probably very controversial to some. To me, it's not controversial at all. So if we look at our AUA and SUO current risk groups, also the EAU, they're almost identical. A low risk bladder cancer patient is a solitary primary TA low-grade tumor, relatively small. As soon as a patient has another tumor, no matter how small, could be 2 millimeters, they are now intermediate risk. 2 or 3 small subsequent tumors. To me, that makes no sense. Why is this important? Because if you look at low risk, for instance, you shouldn't use BCG, and you don't have to do subsequent upper tract studies. For intermediate risk, BCG is a consideration, and you're supposed to start doing, particularly with high grade, upper tract evaluation. So I think that's wrong. My own feeling, and I've now published with others and myself 3 articles, some of which are commentaries. I think low risk should be any low-grade TA tumor. Intermediate, if it's high grade TA, then yes, absolutely, the risk goes up. So I think the reason that they did that is it's based, you have to do two things on risk group. One, there's a risk for subsequent tumor, and there's a risk for progression. So I think no one would argue, and I've talked to Sam Chang about this, low-grade TA, the risk of progression is extremely small. Yes, the risk of a subsequent tumor can be up to 50, 70%. And I think those should be separated from each other in terms of consideration for management, talking to the patient, prognosis, et cetera. So I think there should be a risk-adapted management of low-grade TA tumors, focus on minimally invasive treatment, reducing costs without sacrificing oncologic outcomes, and avoid routine upper tract imaging during surveillance for the low-grade TA. I think we're beginning to do that. Now, one caveat, which I think is quite important, is that pathologists more recently have altered their grading. So Som Lokeshwar, who is about to be a urology resident beginning in July, worked with me when he was a medical student at UM. And we looked at the TA, particularly the TA tumors and their grading between two different periods of time. And let me hasten to add that there is no subsequent article in the last 5 years after this. And I've been asking for some major center, for instance, USC would be a great place to start, to look at all of the TA tumors and see what the grading has been from uropathologists. And we found a dramatic reduction in the tumors are biologically the same. They all look the same to me. They all look TA low grade. However, it used to be a third of those patients were called low grade that I thought endoscopically were low grade, down to 14%. So any degree of atypia now, more currently, seems to be called either grade 2 or high grade. And I think that changes what we might do. And I don't think there's any difference in the biology. So that's 4 areas. Now, the 5th is endoscopy and TUR BT. Now, no one in the room knows what this is. This is a cystoscope, that you know, but no one in this room, I'm sure, except for me, has ever seen these light bulbs. And when I was beginning my urology residency, maybe as a medical student, I actually saw these in use and promise you, you could not do anything. How these urologists did any management of bladder tumors with these little incandescent light bulbs and the instrumentation, of course, it's gotten much better. But a TURBT, I think, is a deceptively difficult operation. And in fact, as you know, is the basis for all subsequent bladder cancer management decisions. And I think this is underappreciated. There are very few courses. In deference to the great laparoscopic surgeons in this virtual world we have today, and in this big meeting room with Gill and Sotelo, et cetera, there are so many wonderful courses on how to do robotic surgery, but very rarely, maybe one in a whole conference, you're going to see a workshop on a TURBT. And I think that's quite unfortunate because it's not necessarily an easy operation. So there's my perception, there's a wide variability in the skill of this very common operation. There are very few articles and little emphasis on technique. There's a lack of guidelines of what constitutes an adequate resection, and a complete tumor resection should be attempted. That's, of course, we all know that. However, several years ago, I did a retrospective review, if you will, of patients that came to me within 4 weeks of a TURBT. So these were very good community or other urologists who I knew. There was a patient that said, Dr. Soloway, can you evaluate the patient? 70% of the time, I went in within 4 weeks and there was still tumor there. So a complete tumor resection is often difficult or impossible. Of course, we've come a tremendous way in our technique, but there's so many variables that we can still learn about and improve upon. Mm-hmm. So one of the things I think was a contribution, I think we can go further with this. This was the first initiative. David Tan, who was a fellow now in Australia, the importance of the TUR in managing patients with urothelial carcinoma. What about a very complete checklist? And this began because very often a resident would come to me in the morning and we're going to do a list of TUR BTs. And I would say, all right, tell me about the patient. Well, I say, Dr. Soloway, I just found out I'm covering you yesterday and da-da-da. What was the upper tract previous report? Did he have intravesical therapy? So there should be a checklist that we would go over prior to every case. And this is, I'm not going to go through all the detail from that 2012 article, but one should review the history before you take the patient to the OR. Look at whether there was imaging, whether they needed it, what did it look like. Very important, discuss with anesthesia. I always like the patient to be paralyzed, endotracheal tube for almost all cases. Make sure your equipment that you want to use is there. Document the procedure, post-op care and pathology review, and then the management plan should all be part of it. Do you want to have urinary cytology? If so, you collect the urine right away. If the urine's all on the floor or in the pan, then you can't collect it. So every time I put the initial sheath in, I collect urine and decide whether I need it to go for cytology. What lens do you want to use? I think you should always, after you introduce the scope, look in the bladder with the 70-degree lens. Everyone doesn't do that. You want to assess the grade and stage before you start your BT because that's going to tell you the depth of resection. What is your goal in terms of depth? Try to be complete, of course. Use augmented imaging with NBI or PDD if you prefer. Angled loops, if they're available, I think you should use them for certain parts of the case. You want monopolar or bipolar. The height of the irrigant is really important. The nurse should not establish that. You should. Do you have to do anything with the prostatic urethra? So that was my fifth area. I can't finish this without thanking really some people who are so important. Lester Persky, who was my chairman, allowed me to set up the laboratory. Al Ketchum, who was the one person who decided who got into the NCI. My fellowship changed everything. Jean de Kernian, I've already mentioned. The editors, if you don't get published, guess what? You think you're doing great work? You thank those editors because they're the ones who made the decision. And these are the list of the editors that were very important over the years in allowing me to have those papers I mentioned published. And I had great pathologists to work with. That was critical. Wonderful fellows and residents and lab technicians were all critical. So just in summary, number one, the cure rate for advanced bladder cancer was dismal. How did I approach it? The animal model, and with great fortune, serendipity, realizing cisplatin might contribute to that. Number two, radiation therapy still is a mainstay for a high percentage of patients, incorporating the use of cisplatin, first starting in the animal model and then the human, and that's currently a guideline. What about the high recurrence rate? Can it be reduced? Implantation may be a factor. Intravesical therapy seems to make sense. I think there's over-treatment for the low-grade TA bladder tumors. I think we should be considering active surveillance off as cautery, and that's been one of my more recent passions, trying to see if urologists will change their attitude and management, just like we've done with small renal tumors and active surveillance with prostate cancer. And lastly, endoscopic management, TUR BT, is a potentially difficult procedure. We should have more emphasis to discuss it. So what are the keys to innovation? Listen, I'm not any better, not any smarter than anybody in this virtual room today. I realize that. I think you have to know yourself. For instance, I'm not a molecular biologist, so I tend to take something that I think we're in management of patients, say, how can I make a difference? If it needs to go to the laboratory and deal with RNA and DNA, I'm not going to do that. I'm not going to tackle that one. So select a topic and then know everything you can about it. Of course, you have to put in the time and effort, but we all have the opportunity to make a difference. So I'm sure I've gone way over my time, but I hope it has been worthwhile, and I think would be a very good time to open up for questions.
Fantastic. Virtual applause from everybody for that wonderful talk. We have about 15 minutes. I know that other people have things that they need to get to. With 130 online participants, I'm not sure we can just open broadly to questions. You have some cases prepared, Dr. Soloway?
I do, if I can get to it.
Okay, well, why don't we do 1 to 2 cases depending on the time, and we'll try to stick pretty strictly with the 8:30 ending. While you're pulling up your cases, I'll introduce our panelists. We're going to have the USC chief residents as our chief panelists today. Eli Thompson, if you are online, please introduce yourself. And Dr. Anirban Mitra.
Hi there, I'm Eli. I'm one of the chief residents with Anirban.
Great, thank you. And Anirban? Okay, I'm not sure if Anirban is online right now, so we do have some backup panelists. Dr. Sam.
I am online, sorry, I just realized I was muted.
Oh, fantastic. All right, great, Anirban. And then we'll also add Dr. Sam Gadusapur to our panel, who is our current SUO fellow at USC, graduating this year. So you guys will be our chief panelists, and then we have for backup Dr. Sia Danishmand, Dr. Sumit Bamvadia, and Dr. Mahir Desai as faculty backup. But I think that we'll have our chief residents and our fellow as our main panelists. Are you ready?
Can you still hear me?
Yep, absolutely.
All right, because I cannot, and can you see the slides or no?
Not yet.
Okay, you may have to help me with that because I can see them, but somehow I've lost the...
I think if you go to the bottom of your screen, you can, there should be a green share screen tab. I think Gio's going to talk you through that. While we're working on that, maybe we can just have some comments from the faculty who I mentioned on the panel, if they have any specific comments on Dr. Soloway's talk. I will start by saying Dr. Soloway's management of low-grade bladder cancer and his real support for managing these patients in the clinic without anesthesia has certainly revolutionized my practice in the clinic, where I feel much more comfortable not taking patients to the operating room and using quite a bit of fulguration and really saving these patients quite a bit of morbidity over time. I'm curious who else may have a comment, Sia, Sumit, or Mahir?
Yeah, I just wanted to make a comment. Hi, Mark. Great talk. Thank you for that. I also have been doing much more in the clinic over the past few years, especially with low-grade tumors. One of the things that's a little bit frustrating is the cauterization with the Bugby electrode. And I know Greg Herman from Copenhagen has been using the diode laser. I am just curious if the diode laser is even available in the US. I'm sure dermatology uses it. I'm sure the technology is available, but whether this is something we can acquire, because it's a much cleaner management for the low-grade tumors.
Oh, I think anything we can improve would be good. I agree. The cautery thing is really small. I've asked Olympus, they don't do that. They don't make it themselves. I think the laser, I've never used a laser in an office setting. So I'm going to leave that up to you and your colleagues to see if we can improve. I think that's extremely important. One of the things I didn't realize, in all of Australia, every patient goes to the operating room with a bladder tumor, regardless of the size, because they do not even have flexible cystoscopes in their office. That's incredible. They could be saving so much money not having people go. The same as in most, like in UK, again, same story. So we think in the US, every urologist has a flexible cystoscope in the office. That is not true around the world.
Okay, why don't we go ahead and start with the case since we just have about 10 minutes.
Okay, we'll go very quickly then.
Thank
This
you.
is a 66-year-old healthy man, former heavy smoker, 5-year history of low-grade TA bladder tumors, last episode 9 months ago, upper tract evaluation normal 5 years ago, new papillary tumor. So here you go. What would you suggest? You're in the office right now. Here's your endoscopic view. What do you do?
Eli, let's start with you.
Sorry, I forgot to unmute again. So he certainly has, risk factor history of smoking, but the long history of low-grade disease, the fact that he had one kind of 9 months ago, he has recurred within a year, so kind of more intermediate risk. But given the look and multiple low-grade tumors in the past, I think I'd offer an in-office fulguration for him.
Perfect. Okay, that was easy. I agree with you 100%. That's what we'll do. Now, upper tract evaluation, Eli, was 2 years ago, was perfectly fine. Does he need another one?
For low grade, I don't think he needs another one now. If he were high grade, then every 1 to 2 years. But right now, I wouldn't proceed with one.
Okay, I agree. And let's skip that. All right, next patient. That was good. So the next patient's a 73-year-old healthy man, 20-pack year history of smoking, hematuria. He had a CT scan. Who's the victim here?
Honorbon, let's have you be the discussant.
So that looks like at least a 2-centimeter tumor on imaging. I'm sorry.
73-year-old, first episode hematuria. And here's your CT scan. Upper tracts are normal.
So this is a guy that needs to go into the OR for a formal TUR.
So I didn't hear that. Take him to the OR?
Take him to the OR for a formal TUR BT.
Okay, would you do a flexible cysto in the office first?
We certainly will look in the office just to make sure that that's not a blood clot. I can't tell which section this is in terms of imaging, but as long as it's not debris or something like that within the bladder, this looks like a problem.
Okay, so that's what I did. I did a flexicysto, papillary tumor, left trigone. It's got some BPH components, made it a little difficult initially, so I took care of that. Here is the tumor. What do you think the grade and stage is?
So at least definitely looks papillary. Probably low grade, but I can't tell that for sure. I also cannot see if there was one stop, but at least on the bottom right after cauterization, it does look like there was a single stop likely. And assuming that there is no other CIS around this, it's probably again a papillary tumor, likely low grade.
Okay, TUR BT, good. Everything you said is 100% correct. Would you give him intravesical therapy afterwards?
I would. Again, if there was no concern for any sort of bladder perforation at this point in time, I will give him some post-TUR BT.
Okay, and what do you think about this? Here's a histology.
That definitely looks like low grade.
Perfect, good for you. So now, anything on this slide? Anything you want to add, higher power?
I don't know smack in the middle over there if those are some enhanced mitotic features. The dots right there, but I think that would likely be the case. I'm not entirely sure.
Okay, excellent. So you're really an A+. So their final pathology report, because there are a couple of areas, this is what makes it difficult. Most of these cells are very uniform. And again, I'm not a pathologist. I just talk to them a lot. So I don't pretend to be one. But so they call this primarily low-grade TA, but there are areas that might be called high-grade. And again, this was the final report, as I indicated. Just FYI, this patient subsequently has a very tiny subsequent tumors. This is now 3 or 4 months later, and then 3 months after that, and I'm just monitoring these, active surveillance. So, next person.
Sam, let's have you as the next discussant.
Actually, I may give you two because I'm not sure. This is just an example. This is a 67-year-old overweight gentleman who I've taken care of for a long time. 2012, he had a BT high-grade TA. He had BCG at the time. And let's just look what's happened over a number of years. I started taking care of him at that time. He had low-grade TA. Office cautery is OC. Office cautery mitomycin. Then he had no tumor, office cautery. And look at all the times that someone might have taken this patient to the operating room, and I'm doing active surveillance, office cautery, et cetera, over all of this period of time. And more recently, in August of 19, after now 7 years, if you will, he had office cautery number 17 in 7 years, you see here. So more recently, he had this. Now, let me ask, who's the gentleman that I'm talking to in this case?
Dr. Gadusapur. He's our SUO fellow.
Perfect, perfect. So when you do a TUR in this patient, just tell me technically, what is your idea of what depth you would like to have? Is he there?
Tom?
If Dr. Gadusapur is not on the phone, Dr. Ahmadi Hamid, are you on the phone?
Yes, can you hear me?
Sorry for the surprise.
No, totally fine. Yeah.
So Dr. Hamadi, you see this tumor, you saw the previous history, 7 years, low-grade TA tumors. How do you want to approach this? Because it's fairly large, I'm going to remove this.
So I start with just doing a superficial resection, just make sure I go superficial to get the tumor. And I probably send it separately. And then when I want to go deeper, I'll probably make sure to just go deep enough to get some muscle in the specimen, but obviously not too deep to perforate the bladder.
Okay, so a couple very quick back and forth. One, why do you need muscle?
So it's a high-grade TA. There's a chance of staging for high-grade TA, so I just need to make sure I got muscle in the specimen. So I think it's important to, given the first resection you could do a good job doing the resection, you don't have to go back and actually do a re-resection.
And would you use, first of all, use monopolar or bipolar?
I use bipolar.
Okay, and would you use MBI or PDD?
PDD, which is what we have here, blue light, I probably use that because I have more experience with that. I haven't really used MBI much.
Good. And do you prefer with the TUR BT 12 or 30-degree lens?
Should do a 30-degree lens.
Okay, very good. The only thing I probably would disagree, and again, this is very personal, et cetera, is I like to avoid this guy is now, what, 8 years, he's never had a tumor that's even T1. So, and he's going to have in the future many, many more resections. We've all seen the very rare but occasional patient who becomes a bladder cripple because of or their ureteral orifice and amazingly dilated after so many resections. So I'm going to probably limit this to only lamina propria, and I don't think you have to get muscle. But I realize that's one of the things we could talk about in a course. Okay, who's the next one for the next minute or two we have?
I'm going to call on Wesley Yip, who's one of our senior residents.
Are you there?
Hold on, am I unmuted? 65-year-old woman with dysuria, normal CT scan, has a bladder tumor and TUR'd at this point about 3 months ago with high-grade T1. Has she been re-resected? Just to confirm that this is appropriate staging grade.
Perfect, perfect. So here's her cytology, positive. Here's the pathology, high grade, minimal T1. So I did just what you said, did a re-TURTP, VT, and there's high grade T1 with just a little bit microscopic invasion to lamina propria. So this is her second TUR. Now what?
I guess at this point it becomes a discussion with the patient what our treatment options are, because while we could pursue intravesical therapy, she could also be a candidate for upfront cystectomy.
So that's, you're being very provocative. Okay. So I like the discussion part with the patient. So be more specific. This lady is, first of all, is a physician, extremely anxious person. And yeah, okay. So she hasn't had any treatment so far but the 2 TURBTs, correct?
That's what it looks like, yes.
Okay. So you're going to discuss a cystectomy?
Well, we could discuss the 2 paths that we could go down, because we could go down intravesical therapy, at which time she would have to come back for repeat office visits to get it done. We could talk about potentials for delaying cystectomy and potentially worse survival outcomes by doing so. So I think it's kind of just a long discussion about how those 2 treatment pathways would go.
So let's assume we don't do a cystectomy. What would be your next step?
We can go with induction and BCG for her.
Okay, so this is the TURBT, just to give you an idea. So it was a very small area, and I did, I think, a pretty reasonable resection. So gave her BCG, and she had a cystoscopy after the BCG. Bladder looked absolutely fine, cytology negative. Should we give her maintenance BCG?
Given her risk, then yes, you would continue on a maintenance BCG.
Okay, so the 2 things I would bring up in this case, first of all, personally with T1A, I would not at this point suggest a cystectomy, because what I always think about is the likelihood she's going to be PT0 is extremely high, because she just had minimal invasion, number 1. And I think, what if this is a rare patient, and you say, well, gosh, you're what kind of person are you? What do you think about that day 7 or 20, whatever, is you think you're the most perfect surgeon, has a PE and dies, and she had PT0. Would you feel terrible or not? And I would say, I would, because I once, this is about 15 years ago, a faculty member at another place called me about exactly this situation. And I was commiserating with him. So I think I would feel horrible. I think, geez, I went ahead. So again, yes, there is always a risk with T1 that you're understaging. So I think the real question would be, should I do a 3rd TURBT or go ahead with the BCG? So everything else I would absolutely agree with your comments, and I would give maintenance BCG. So again, no perfect answer, but that's just my thought. She had maintenance and she's fine. Actually, I had to re-biopsy her at one point because I thought I might see something. She's 3 or 4 years down the road and NED. Here, this will be the very last case. 78-year-old healthy man, long history of bladder cancer. This is a very long history, somewhat unusual case. Maybe, let's keep, is that Wesley you're on? Is that right? Was I just on with Wesley?
Yes, still here.
All right, let's keep going, because this is going to be interesting. You may turn out right at the end. So 2003 was his very first low-grade TA tumor. He kept being followed, everything fine. And you see in 2015, everything was fine. Then he had office cautery, long history. In 2019, so this is now 16 years after his first tumor, he's got a little small tumor above the right ureal orifice and the posterior wall. And it turns out it's a high-grade T1 signet ring. I think I might have, here's the tumor, here's the resection, here's the pathology. If we had more time, I'd ask you what this was, and I'm sure you would say that's a signet ring tumor. And there's the higher power. So now what to do?
Well, variant histology also is something that you can include in the discussion for high-grade T1 and possibly considering cystectomy up front.
Okay, and what would you choose? I would agree, absolutely. That would be a really important discussion. So the lesions are actually really small. I was just shocked when I saw this result. So he's got high-grade T1 with signet ring after 16 years of low-grade TA tumors. So would you err towards cystectomy, or what other choice would you have?
I mean, I think in this patient I would.
Okay.
Why don't we open this up to our faculty panel and take their opinion?
How about you, Dr. Schuchman?
Yeah, I mean, I think I would in this patient err towards cystectomy. I think the signet ring is a very poor prognostic indicator, and this is not a patient who I would expect to have a great response to any intravesical therapy. And I would have a discussion about cystectomy at this point.
Okay, I think that's certainly reasonable. So what I did is I said, well, let me do it, because they're really small. I did a TUR BT, and sure enough, there was signet ring again. I was like, I cannot believe this. So I did another TUR BT, and at that time there was no tumor. And I just re-resected him because I wanted to make sure after a few months, and right now he's tumor free. So this is really a difficult decision. Again, I'm always thinking of the worst case scenario if I do surgery. Look, most of the time we do amazing surgery, things go really well, and you're done with the problem. And I think when you do bladder preservation, and we've all had cases where we have bladder preservation, we're trying to avoid a cystectomy, and it turns out bad, and we've got positive lymph nodes in 10% of people at T1. Well, with that, the hour has gone by so quickly. I would, first of all, thank you for this. Thank you for Gio for helping me the other night to get this started, that it actually worked. I feel so good about that. Indy, I really appreciate the opportunity. And let me just say that I have no idea how many people were on the other side. I hope some people will email me with questions, thoughts, arguments. And if in the next couple of weeks, if you want to start out with cases or another 20-minute talk and then cases, I am absolutely available. It's worked perfectly, and I really appreciate this opportunity.
Thank you so much, Dr. Soloway. This has just been fantastic. Just to let you know, we've had about 130 participants actually on this Zoom call. So this is being recorded, and hopefully we'll have a chance to post the videos so people can come back and look at this and we can distribute it. I'm getting amazing real-time feedback from people. This has just been fantastic. So thank you so much for your time and participation from our esteemed panelists, and stay safe. And thank you for providing an educational opportunity for us all in this challenging time.
Thank you very much, Ann. It really has been delightful. Indy, you're the one who started this. You got to keep it going.
Thank you. Thank you, Dr. Soloway. Honestly, this is our first foray outside the four walls of USC. And as Ann just said, thank you, Ann, for your hosting this morning. As Ann just said, over 130, 140 people participated from various institutions, urologists, residents, program coordinators, etc. So you surely know how to draw a crowd, Mark, and your charisma and your reputation precedes you. We will take you up on your offer to do just a case presentations and have all the residents show up. So we will line this up. I think we are out of time, so I'm going to hold back on, I just wanted to have a personal conversation with you regarding thoughts about your career, etc. Maybe we will do it the next time. But again, thank you so much. And thank you to everybody for participating. This has been a really a learning for us. If by just getting the appropriate experts and setting up a program where we can exchange thoughts and ideas, if we can impact 140, 150 or so urologists in this day and age when most of us are not actually active in the operating room, I think is a big one. And I think the coronavirus has changed us permanently in many ways, and this may be one of them. Thank you so much, everybody. Have a great day. And again, a round of cheers for Dr. Soloway. Bye-bye.